The next presentation is going to be on myopia management, and to give you an overview of what's happening in myopia management at the moment. So I'm really delighted to have Dr. Neema GHORBANI-MOJARRAD with us today. Neema is an associate professor at the University of Bradford in the UK, and he is a locum optometrist as well. He finished his PhD at Cardiff University and has previously worked full-time in an independent practice. He won the newly qualified Optometrist of the Year award, and his current research interests include the genetics of refractive error, contact lens and anterior eye, understanding the causes of myopia and interventions for myopia management. And he currently serves as the chair of the British and Irish University and College Contact Lens Educators, and an editorial board member of Acuity and BMJ Open Ophthalmology. Neema is the recipient of both the College of Optometrists George Giles Prize, the VDCO Peter Abel Prize, and he's also the recipient of the 2022 SILMO Academy bursary. And that's when we first met, actually, and we've done now a lot of projects together. So please welcome Dr. Neema GHORBANI-MOJARRAD. Thank you, Neema.
Bonjour, can you hear me? Excellent. I'm sorry that this is going to have to be in English. My French is nowhere near acceptable enough. But yes, thank you, Elaine, for the invitation. I'm here to talk to you about some updates in myopia management, specifically some of the things that have happened over the last year. Now, I'm going to say that I wrote this presentation in approximately May, June time. It's already out of date. Things change so much and so quickly that some of the things that I will present to you, I will even give you further updates that have happened over the last month or so. So these are just my declarations of any kind of relationships I've had or have currently, but I just want to make clear that no one has had any input into this presentation. It's continued from me. Okay, so as Elaine said, I am an academic, so I have to give you some learning outcomes to what you should know from this presentation. So by the end, I hope that you have learned some new technologies for myopia management, some of the advances in how we understand how myopia management works, know some of the communication tools that have become available globally for myopia management, understand some of the things we don't know. So we will hear a lot from many different people about the new advancements, but what don't we know about myopia management? This is something that I will also try to talk about, and also just some of the arguments for different ways to approach myopia management. So, what's the current global state? So this was the most up-to-date survey that we have at the moment that's global. This has a wide variety of practitioners surveyed across all of the globe, Africa, Asia, Europe, Americas, everywhere. Generally speaking, the amount of people that are getting involved in myopia management is increasing. And we can see that generally speaking, the most important thing that people find is that parent preference and patient preference and what the parents and the children decide themselves is much more important than the actual refractive error that we may have in front of us when a child wants to do myopia management. Interestingly enough, though, if you ask the practitioners, at what level of myopia do you think we should start to prescribe? Generally, everyone thinks at 0.50 to -1. That's the most common. Whether that's proactive or not is actually a very personal decision. For me, I would prescribe more early than that because there's evidence that it works even before you're myopic. However, that's not what the majority of practitioners do. And this kind of attitude varies across the world. It was myopia management is least common and less understood in Africa and South America, but much more common in Australia, Europe, and America. And this is kind of the reason I was asked to give this presentation, is because of the amount of change that's happening. So in myopia management, or myopia in general, our understanding, over the years as time has gone on, we have had more and more papers published in this subject than before. So in 2000, we had maybe just less than 500 papers for myopia, or related to myopia. And as of last year, in total, we had well over 2,000. So the rate is exponential. And I'll be honest, I can't keep up. There's a lot of information there, the information is very nuanced, and some of it is conflicting. So some things will tell you something is working, sometimes things will tell you that it's not working. However, regardless, the amount has increased. So this is almost at an exponential level, and this will continue to rise. I think already in 2025, the number of papers has already exceeded this number. Okay, so why are we more interested in myopia than before? Well, part of that is because of the risk of pathology. So although, you know, we could argue we're in SILMO right now and there's a lot of frames here, a lot of lenses, and we could make a lot of money from all these people becoming myopic, but actually we are concerned about myopia. Why are we concerned? We're concerned because we don't want people to have the side effects or the associated risks with myopia. So that comes in the fact that the eye grows too long. With the eye growing too long, we have an association with retinal detachment, we have an association with things like cataracts, we have an association with things like glaucoma. There's many different diseases that have been shown to be associated with an increased amount of myopia. And actually, it begins to get worse when you have an axial length or an eye length of 26 millimeters, or the prescription is over -6. However, the better one is when it's over 26 millimeters. That's much more sensitive, much more accurate. But that's why we're interested in myopia management. And we can see here that over -6, you have a 39% increase. Now, it's interesting that I mention a percentage there. This percentage is something that I will talk about in a moment, but the risk increases by 40% on average when you have a high amount of myopia. So, let's talk about some new technologies. So, we know spectacles exist, we know contact lenses exist, but what we don't know about is more about light therapy. So red light therapy is something that is kind of expanding in its approval around Europe. I don't actually know if it's approved in France. I wasn't able to get a firm answer. Elaine shaking your head, thank you. But it is available in the UK, and it's available in Turkey, and I think it's available across several parts of Eastern Europe, and also a lot of Asia and Australia. Along with other places, and I think each year the number of countries begins to increase. But light therapies are becoming more popular because they are something that you could potentially do at home. So repeated low-level red light therapy has a license. China has paused approvals for this because of the number of copycats. So China made these and then realized that everybody wanted them, so as China does, made a lot of the same ones or different ones, and now that's kind of gone all over the country, but they've now paused the manufacturing of that because they are trying to regulate it. However, there are some that are approved in the UK and across the world, and those have shown through clinical evidence that they do work. So there's a significant efficacy shown when you use the machine 2 times a day, 5 days a week. However, there's a few things to pick up here. So if we look at the the right-hand side graphs there, the first one is showing you the change in refractive error that happens over 24 months. In these groups, for the first 12 months, every one of those children, 50% of them had a treatment for red light therapy, 50% of them didn't have that treatment. And you can see for the first 12 months, half that graph, there is a difference between the amount of growth that occurred for those children. That was the demonstration that it works. For the next 12 months, the organizers of this research, they decided that they would swap it. So 50% or half of the children that had red light therapy would stop, and half of those that didn't have red light therapy would start. And the idea was to see if you could do it later or if there was any rebound effect. And the thing that's important to bear in mind is that there does seem to be a rebound effect. The orange line that you see is the group that had red light therapy for 12 months and then stopped. So it does seem that when you stop using the red light machine, especially in these children, the amount of myopia reduction or the amount of myopia progression increases more than expected. You essentially catch up to where you may be before. Okay, so the treatment may work, but you have to be careful to continue to do it in order to be okay. The graph that's on the bottom right here, that's the same data, it's just for axial length or the eye length. And you can see it mirrors the other one there. So there is a potential rebound effect that occurs with this data. However, we're not so sure about the safety of this. That's one of the reasons why China has sought to regulate it. Red light therapy uses lasers, and although many machines use lasers, this is a laser that directly goes into the eye. We are not 100% sure how safe that is for long-term use. Currently, the machines that are provided for for use and are licensed and registered have 4 years where they're approved for use because that's how much data they have. But over time that may increase. However, there have been reports that that has caused some damage in a rare number of cases. I believe the cases at the moment stands at 5 out of 165,000. So it is there, it is something to consider. Now I talked about red light, let's talk about blue light. So this is another new technology. And it's currently in clinical trials across Europe and America. I believe that includes the UK, it includes Ireland, it includes North America, and it includes, I think I want to say Italy, but I can't remember. And this essentially is a bit different from red light therapy that shines blue light into your eye. This is just using a smartphone that chooses a blue light, and essentially it targets children by playing a game. So you're playing a game on your VR through your phone, but the blue light is being shone only at your optic nerve. That's how it works. You won't actually see that blue light when it's working correctly. The game is meant to cause you to look in a certain direction, and by looking in that certain direction, you don't see the blue light. The blue light works on your optic nerve or in your blind spot. And the results of this are quite positive. They've shown that they are not inferior, and what that means is that they are not any worse than any of the kind of proven treatments already. So compared to things like MyoSmart, compared to spectacles and other kind of treatments, this works in a similar capacity in terms of stopping the eye growth. It does that by stopping or keeping the choroid thick through selective blue light treatment. So this is another thing that's coming up. The 12-month data is what I've just told you about now. This will continue for another 2 years, and that data will come out as time goes through. But so far it's looking very positive, and it looks like it will get approval. Okay, so those are the light therapies. There are some other treatments that are coming on. In fact, so many that I had to selectively pick 1 or 2 just for interest. So there are some contact lenses that are coming out that are slightly different from all the other options that we have. Most of the treatments that we have, they will use optical defocus to work. And what that means is they blur on the periphery, preferably a myopic defocus, in that they essentially stop the signal for the eye wanting to grow longer. So some people have started to use that because one of the things that's happened in a lot of the treatments that we have is that the first year that you use this treatment, you get the most amount of effect seen. That could be down to the age. It could be down to getting used to the treatment. We don't know why fully. So this company here, an ophthalmic, they've made a new contact lens, and this contact lens essentially spins in the eye. It's deliberately spinning in the eye. And the reason for that is to make sure that you don't adapt to the visual that you see. And by not adapting, the theory is that in treatment, you'll probably get a continuous higher treatment effect. So it's quite clever, really. This is the power map that they show you on their website. They can't give you too much about the technology. They just call it stop contact lenses. But the idea is that it spins in the eye with blinking slowly to make sure that you don't adapt to the vision that you see. There's obviously loads of spectacle interventions. Some of them you will see here. The ones that we know very well are things like myosmart and Stellest. So I've not included them because they're not very new. They're actually established and well known. But in the last, I would say, 24 months, these are new ones that have come to the market. And if this slide is a bit overwhelming, it's because there's so many that have come on. So we have things from Rodenstock, we have things from Zeiss. Depending on the company that you know, depending on the country you're in, IoT in Spain. And there's also this one here. The one I want to paint the picture of is the one on the right-hand side. That one there is the one that's a new lens design made in China. And it was an interesting study that they looked at there. Not only did they give defocus in a sense of myopic defocus, but they also tested hyperopic defocus. So what's the difference? Myopic defocus focuses the periphery, or the vision, or the light periphery in front of the retina. The idea being that it stops the eye wanting to grow too long. The negative defocus, or hyperopic defocus, does the opposite. It focuses it behind the retina intentionally, but the defocus potentially may stop from growth. And actually, the study showed that they were similar. So what we thought we knew about optic defocus, we are not so sure about now. So optical defocus is a treatment that does work, and pretty much all of the optical interventions that you will see that are licensed all use optical defocus. However, this study used optical defocus in a way that shouldn't have in theory worked, but did work. So now we're not sure what the reason might be. The thinking currently is that it might be on contrast. So it doesn't matter how the defocus works, as long as the defocus causes significant amount of contrast loss. That is what we think many of the optical interventions that we know may be working. So actually, it's an interesting consideration, and many people are now looking into whether they can show that, because newer spectacle lenses that are coming out into the market are beginning to use contrast rather than optical defocus exclusively. So that was a lot of information. I'm sure many of that kind of wasn't well explained enough. So because it's moving so fast, we kind of don't know what to do in terms of catching up with the data. So you may come to presentations like this, but as you can see, there are many empty chairs. It might be that you try to ignore it completely. There are many different ways in which we don't know what to do with myopia management. So one of the things that we've done in the UK, and I'm thinking is going to come to France pretty soon, is to do what's called a Delphi study. A Delphi study is essentially an expert panel where there are ambiguities in science where you either can't research it because of ethical reasons, or because there hasn't been enough time or funding or money or whatever. You cannot do the science to prove a question. So we ask the experts what they think, and if there is a consensus, then we have an idea of what people should do as potentially best practice. We did this in the UK, we did it in 2024, so that was only last year, but it is already way out of date. But I will give you some highlights on this because it was an interesting one. So, things that we picked up. Myopia management should absolutely be discussed with all myopic children. So if you're not sure about whether you should use it for children who are already very highly myopic or children who aren't myopic yet, you should be discussing it with every single child. That was one of the expert recommendations. The reason being is that we don't know, for a non-myopic child or a child that has only just started their myopia journey, how myopic they will be. So this is something that was recommended. Interestingly enough, we do not have enough data on whether it works for children with atypical myopia. What do I mean by this? So myopia that may be due to the fact that they are premature at birth, or that they have retinopathy of prematurity, which is a retinal condition that causes myopia. We have no data to show that works. Interesting fact, there is now a case report of how it has worked for that child. So actually it could be the case that you can use it, but at the time, there was no data for that. The other really important thing, no single optical intervention is better than any other. So we shouldn't be considered about looking about numbers and saying this one does 79%, this one does 69%, I really need to focus on that. Percentages can be misleading. Actually, no thing has shown actual clinical superiority, so the treatment you should use is the one that the child will wear or the one that best suits their lifestyle. If that child doesn't want to wear glasses, wants to wear contact lenses, please go with that option. If the child doesn't want to try anything, try something like atropine. There are many different ways out there, and you should basically try and find the one that works for the child as well as the parent. Now, atropine is something I just mentioned there. The results as to whether they are suitable in lower concentrations, and by that I mean 0.01%, we are unsure. We are unsure if that is powerful enough for treatment in children. Why? Because some studies have shown that it does work, and some studies have shown that it doesn't work. Interestingly enough, some of the studies showed that it worked in European children, and some showed that it doesn't work in Asian children. So it might be to do with the amount of pigment. But we truly don't know because there's not enough data to make that decision. Either way, we need more data before we license that product. If you are to see a child for myopia management, 6 months intervals are the most suitable. So you want to see that child every 6 months. You'd want to see them as regularly as that. And here's an interesting one. Treatment success is very difficult to determine. So once you fit a child in myopia management, it is very, very difficult to try and get them to basically to see, has it worked? Because when you fit that child in myopia management, I don't know what that would have happened if I didn't. I usually don't have a twin that does nothing and I can see what happened. That doesn't work that way. So I can never tell how much of a change there would have been. I can't tell if there was no change expected. So it's very hard to determine right now, as we currently understand it, how much of an efficacy has happened for that particular child. So just using a growth chart, just trying to look at the previous progression is not enough. We don't have the answer to how. Those are the best things we do have, but what we're saying is for now, what we do understand is that is not enough. Another thing, interventions may need to continue beyond young children. So although myopia most commonly takes place and starts between the ages of 8 and 12, it still progresses. and it still can progress and onset beyond the age of 18. So some of the work we've done has shown that actually, if you're in university, 1/3 of all myopes will continue to progress in university. University is a very, what we would say, myopia-genic environment. It causes you to become more myopic. Education generally does, and I'll touch upon that in a moment. So for that reason, it might be that actually myopia interventions might be very suitable for someone who is an adult. Please consider it. Keep an open mind. And if something has been shown to work and you stop it from work, and you stop it because you think it's done its treatment, but the patient progresses again, you should consider restarting a treatment after 12 months where you've seen that there is any progression again. And this is because, again, we don't know when something has been successful, because we have to stop it to see if there's any progression afterwards. There's been minimal evidence to show that optical interventions have a rebound, i.e. when I stop using it, does that cause the child to essentially become more myopic than we expected? Much less evidence for that than the light therapy that I showed you a few slides back. However, if you find that the myopia progresses, you should continue to restart that child on that treatment. So essentially you have to be active even after you've stopped the treatment from taking place. This is always a controversial one for parents. You'll hear many parents say that you should stop using screens, you should stop your children on their phones, you should stop them on the PC. And there's been very difficult evidence to prove on that, whether it is actually something or not. Evidence is now suggesting that there is a small effect on screen use for myopia risk and progression. So prior analyses that combined everything together have shown that actually we weren't sure. This one here actually took it a bit further. It looked at how many hours you are on a screen per day and how much of a risk you have of myopia from that. And here you can see a dose effect. So essentially the more hours you are on a screen, the more likely it is that you will progress in your myopia and your odds of myopia. So this is much less ambiguous now. We have a much more higher risk for becoming myopic if you continue to use screens more per hour a day. Another big thing, education has been shown to actually be a direct risk factor. And when I say this, I mean it has one of the strongest levels of evidence to being a causal risk factor, i.e. education actually causes you to become myopic. So here we can see that when we've looked at children, generally speaking, those that go to university become myopic and actually progress and continue to become myopic. Why is it that education causes someone to become myopic or progress in myopia? Well, 40% of it has been down to the fact that you spend less time outdoors. What's the other 60% is the big question. Maybe it's the screen work, maybe it's the close work, we don't know. But 40% of it has been attributed to spending less time outdoors, okay? So think about the fact that we have school from September to about June, July, depending on where you are. All of that time you'll spend less time outdoors, and part of that doesn't include the summer months. So that might be part of the reason. So yeah, 60%, we don't know why it does, but we just know that without fail, education is a really, really strong risk factor for becoming myopic and progressing in your myopia, about 0.25 diopters a year. But with that in mind, this is a lot of information if you were to try and give it to parents that might ask you a few questions. So there's many tools available, and these are available in France, I believe. So 80%, I was bizarre and shocked by this. All the information you may give a patient about their spectacles, about their dry eye, about their myopia, about anything, approximately 80% of it is forgotten immediately. Think of the last time you went to the doctor. Do you remember everything the doctor said? You may be thinking that you did, but actually you probably forgot most of it. 80% is forgotten immediately. And the more information you give, the more likely it is that it's not only forgotten, it's confused. So many parents will get things mixed up from what you say. With that in mind, there are new applications that you can use to help basically give that patient or that parent more information, and that they have a way to access it again. So I've given the two examples that I know very well here. One is Ocumetra, one is Primo. Okay, they can help you with many different things. They can tell you the current risk of someone becoming myopic or progressing in their myopia. It also tells you the available myopia management options to you, depending on licensing, the country you're in, the prescription the child has, all of those factors. It also allows you to compare it to the age-matched norms. What does that mean? So if a child is 7 years old and myopic, how far ahead in the amount of eye length growth or progression of myopia are they in comparison to the other children of that age? Okay? It also allows you to discuss previous progression, because you can essentially upload the information of their previous prescriptions and put it into a graph format and check the current level of vision. These are very helpful because although we take that something we know very well, parents may not realize that impact on their children. Parents don't even realize sometimes, especially if they have not had myopia themselves, what their child's vision is like without spectacles. They don't understand this. So all of these applications, you can download PDFs to show this. You can also show it online. They're easy to scan. They're just a QR code that you can provide the parent, and you can do them while you see them in that clinic room. But yeah, one thing they also do, which I can imagine is an issue, is that they predict axial length or estimate axial length. So biometry is still the gold standard, but as many of us across the world, we don't have access to a biometer or eye measuring tool in the actual clinic that we work in, so we can use the machines and the estimations from these technologies to estimate how long the eye is, and we can do that at each appointment to get an idea of how things are changing. So I put QR codes if you're interested in those. To give you caveats, Primo, which is the one on the left-hand side, is completely free of charge. You can use that for free. There's no cost. But the one on the right, Ocumetra, does have a cost. It does have a trial should you want to try it. But you can see that in terms of the visual interactivity, it might be a bit better. So it's completely your call on which one you want to use. Try them both, to be honest with you. You can try it on people you see in clinic. That's absolutely fine as long as you have consent to do so. But these tools allow you to talk to patients, allow them to take the reports that develop with them so that whenever they have questions, they can basically look at that page and you don't have to worry that they're going to forget something that you've said. So if you talk about, I don't know, contact lenses are available, spectacles are available, but they might have forgotten one of those options, this will have that in the report. If you're worried they're going to forget how much progression or how high their prescription is or anything like that, those reports will cover those. They are very useful. Okay, this is an interesting one to try and describe. So, whenever we talk about myopia, we talk about a risk to eye health. This is something that, generally speaking, everyone tends to know or has heard of at least at some point in their life. For example, if you have high myopia, as I said earlier, 39% risk of retinal detachment. Here you might have a 20 times greater risk of retinal detachment, and that's compared to when you look at it from an emmetrope. So a high myope at -6 has a 41% greater chance of basically getting retinal detachment compared to someone who has no myopia. That's what started off all of the discussion and interest in myopia management. However, we have to be very careful because it's very easy for us to either misunderstand or for our patients to misunderstand what a relative risk is. That is a relative risk when you are 40 times more likely it's compared to another group, okay? And it's very easy for us to interpret that or understand it in a way that it's not meant to be. So I'll give you an example. I think 5 or 6 years back, there was a big discussion as to whether things like bacon, processed meat, sausages, all these sort of things would increase the risk of cancer. They have been shown in many studies that they do increase the risk of cancer if you consume them more. Okay, to the point where the World Health Organization has that on their website. In fact, believe it or not, things that cause cancer, you've got smoking at the top, and then straight under it, you've got red processed meat. Okay? It's categorized in the same grouping, which is extreme in a way, you might think. But that's because things like this can be misleading. So although you have a 10 to 20% increased cancer risk from eating red meat, that doesn't mean that your risk of having cancer whilst you eat red meat in your life is 20%. It's not. It's very easy to interpret it that way, but it's not. Actually, it's like 0.2%. Okay? So relative risk thinks the overall factor in comparison. It doesn't count the individual and the personal risk to that person. So this was discovered when we basically is a big thing when they talked about red meat and cancer, because if you had 21 grams of meat a day, your actual increase per odds of getting something like bowel cancer was 0.2%. So actually, it's very easy for us to worry people by saying these very high values, 41% times, 410 times, whatever. And they are true, but they don't account for the risk to that child in your chair. They don't account for that individual person. So interestingly, this has now been updated as of this year. There is evidence to talk about what the actual absolute risk to that child is. So if someone asks you, what's the risk of me getting retinal detachment if I'm highly myopic? Parents might ask you that, I'm going to invest several hundreds of pounds for several years in this treatment. What's the actual risk that something might happen? Okay, so the values for Caucasian children are put in this slide. So it's less than 1%. So less than 1% of children, so less than 1 in 100, low myopes are likely to get any form of eye condition from myopia. That's retinal detachment, glaucoma, and myopic maculopathy, okay? For someone who is highly myopic, i.e. -6 and above, the risk is now 6.4. So if you had 100 high myopes, you'd expect 6 to 7 of those people to get one of those eye conditions. That's the absolute risk for that person who's -6 and above. The risks are even higher if you are Asian from background ethnicity. If you're an Asian by ethnicity, it's 1.4 in 100 for low myopes, and about 10. So 1 in 10 Asians who are highly myopic will have one of those eye conditions at some point in their lives. So when it comes to communication of this sort of factor, you might have seen these before when it comes to things like cancer risk, these kind of infomercial pictures of how many is the risk. That's much more suitable than showing someone that table there, which many of us might have in clinic. So yes, it's absolutely true. It's not taking any away from the fact that the risk of myopia conditions is more the more myopic you are, and that there is a relative risk of 41 times for something like retinal detachment. However, when I'm thinking about the child who sat in the chair asking me their risk, it isn't to say they're 41 times more likely, although that is a way to describe it. What I should be saying for you, for a -6 child, let's say, it's 6 in 100 that something will happen to you in that instance. So that's something, again, that's looked through the literature, and people have basically found the evidence for that in all of the reports that have taken place. So I've given you a lot of information there about things we do know. I'm going to now talk to you about things that we still don't know. So this is the sort of thing that we still need more information on. So one of them, can we use low dose, i.e. 0.01% atropine, as a treatment? The arguments for this, well, some studies have shown, well, the reasons for no I should start with first. Some of the studies have shown that there is no significant effect on axial elongation, i.e. even studies that have shown that atropine is actually effective at slowing down your myopia, it may not be actually powerful at slowing down the eye growth, the bit we care about. That's the bit that's related to the eye health conditions and everything. Evidence is really lacking. In fact, it didn't do anything for some of those studies at all, even when they were significant for refractive error. And because of that, if you were to use atropine instead of something else, you could delay the use of more effective treatments. What do I mean by this? If you are using atropine rather than, let's say, a spectacle intervention for myopia management, you may be delaying that effect that you may have on the axial length because you think that atropine will do the trick. And as I said, there's mixed results in trials, and the long-term outcomes aren't clear. And what do I mean by this? So the original studies that looked at atropine in Asia, they followed those children up 16 years afterwards. Okay, so they followed up, I think it was something like 40% of the children that were in the original studies that had atropine afterwards. They followed them afterwards to see what's their myopia doing now. And interestingly enough, they were just as myopic as the group that never took atropine. So although there is a rebound effect known with atropine at high dosage, it may be that the low dosage just doesn't have a rebound effect over the time we measure. So essentially, we don't know if atropine at a low dosage will be effective or not. We just don't know yet. However, there are some arguments for using atropine at this low dosage. One is, some of the studies have shown positive results. More so in European children, the results are much more promising, and we do think it might be pigment related. And for children who are older, so children that are young and have a lot of progression, this might be less effective, but if you are an older child and you really don't want to wear myopia spectacles or contact lenses for whatever reason, low dose atropine might be something. The other thing to bear in mind, because it's so low, it has less side effects. The side effects from 1% atropine are significantly more than 0.1%. So again, it's good to have a lower dose potentially as an option. And the other thing that we're not really thinking about, but we are beginning to see now, is that 0.01%, may actually have an effect when it comes to a combination. So it might be that if we want to use atropine this should be an option alongside something else, because they do work in different ways, and this may allow us to have a better effect on what we're doing. So actually, if we combine it, it might actually have a much more powerful effect. So what do I mean by this? If we're wanting to use atropine 0.01%, we may be able to use it in combination with other treatments and have an even better effect than if we just use the other treatment alone. So it could be possible. We are interested in whether that could be the case, because there are some studies that have shown combination absolutely does work. Okay, another argument that we don't know. Should those combination therapies I talked about be the standard of care? So should we just go straight in with treat with everything possible to do the most amount of effect? So the arguments for why we should do this. I don't know if one treatment will work for that child the best. So if I give them everything, I'd waste less time knowing that something probably won't work or one will work better than the other. I've tried everything at the same time. And generally speaking, for all the studies that have looked at combination therapy, the treatment effect of combination is generally better than any one on its own. If not, if it hasn't shown that, it's at least shown that combination works just as well as one single treatment. So those are the arguments for actually doing it as the first line of approach. However, as I just said, the arguments against it, the efficacy is not always better. So I might be charging my patient double with the same amount of efficacy. For that reason, I also don't know which treatment is the one that's working the best. So my treatment for the patient becomes more complicated. I now don't know what I need to cut out if the patient can't afford it. I don't know what the best thing for the child is. I've just thrown everything at them at the same time and hope that something works. And obviously with patients and the fact that this is a long-term thing, myopia has to be treated throughout childhood and then actually potentially in adulthood too. This is a very costly thing to try, and the risks might outweigh the benefits. This is a debate. We don't have the right answer for this yet, but it's again something to be aware of. Does combination therapy always work? We don't actually know that yet. Another thing to think about, and I think this is relevant in France given the amount of treatment you can provide. You can provide it to certain children, I think, and not others on health. So one of those is, should we be providing myopia management to every child, or should we be providing it to only those at high risk? And this is something that's been considered at many different times, something that as I said, the UK experts advise that we should be treating everyone, but there are different arguments for this. One of them is that treating everyone should reduce the overall progression and prevalence of myopia in the population. As practitioners, that's what we care about. Might not be relevant to that particular child, but it's important. Also, we cannot actually predict which children would become myopic, how myopic they would get. We can't do that. We don't know what they would do, so we should treat them anyway. And also, as a practitioner, I have an ethical responsibility to that child to treat them. It doesn't matter if they were not going to become highly myopic. I just don't know. However, as said, the actual proportional risk is only more concerning for those with high myopia. So actually, it may be that we can just treat those high myopes, okay? And the absolute risk of progression is quite low. And the other thing to think about is that we have limited resources. I hate to say we're not made of money. People aren't, children aren't, the healthcare providers, we can't all have infinite amounts of money. So actually, maybe we should be prioritizing myopia treatment for those that need it the most and not others. Again, this is a debate. There is no right answer at the current moment. There's arguments to and for, and I think, as I understand it, most healthcare regulators that have looked at myopia management as something they provide have gone for it matters in certain circumstances and for certain children with high risk. However, whether that's correct is a decision for someone to discuss. Okay, another thing that we don't know. We have evidence that myopia can be delayed or stopped. Okay, so if you have a child who looks like they're about to become myopic, interestingly enough, most of the treatments I've talked about today, if you prescribe them before they become myopic, they have an effect. They can either prevent myopia entirely or delay it in some children. So should we be offering pre-myopia treatment to everyone? So the argument is that red light therapy, atropine, myopia spectacles have all been shown as a statistically significant effect on basically stopping or slowing myopia onset. And in the long run, they may not have to have an optical correction that's too high anymore because you've stopped the myopia even at an earlier stage than it would have done. And actually, myopia onset, the eye growth, is all greatest in the year before the myopia takes place. So the most amount of change you will get is in the 12 months before the myopia onset. So that would reduce the final amount of myopia by a significant amount. However, that's a significant investment. Basically, you're saying try and preemptively delay something that you don't know if it will definitely happen or not. Okay? And actually, what I'm also doing is asking someone to take a treatment with spectacles and wear them when they don't need to see them. So most children will not wear spectacles if they don't need them to see. If they don't see a visual benefit there and then, I mean most people for that matter, they're not going to wear them. So getting adherence to that treatment that you're providing is going to be difficult. And the effect is not as consistent as expected. Not all children behave as an average, so some of them will absolutely stop growth entirely. Some of them, it won't change anything really. So it's something you could offer for those very paranoid, but actually it may not be the case for every single child. So in total, it may be difficult to get a child to wear correction they don't need. If you have someone who's very keen, there's an option that it can be because it's been shown to work, but that's a decision again that we don't have a full answer for. And one of the other things to mention, as I said earlier, red light therapy, the safety is now something we're not sure about. So would you want to give something that isn't actually going to be necessary directly then, if it's not safe? That's a question for you to discuss. So, to summarize, I've gone through some of the new information we have about risks of developing myopia and its rate of progression. We've gone through absolute risk, we've gone through the actual risk and why it's important, and we've gone through what sort of factors such as education and contrast, etc., all of those different factors. We've talked about how the new technologies, which ones they are and how they might work. As I said, we're more thinking now about contrast reduction, not just purely optical defocus alone. We've talked about the communication tools that are out there, not only to help us estimate axial length if we do not have a biometer, but also to help us with the communication with our parents and children, because again, communication is the core concept of keeping your children compliant, using treatment, or even if you want them to consider treatment, you need to make sure you communicate what you're trying to say effectively and something that they will remember and be able to call back at a later time. We've talked about the difference between what an absolute risk is and a relative risk, and when it comes to an individual person, how we should talk about absolute risks to that child or to that person. And that, yeah, we will continue to learn more about myopia, okay? Sometimes we have more questions than we do answers. As we learn more and more, we actually realize we know less and less. So although we now have treatments in place, how we best use them, who should be treated all the time, how should we treat them, what treatment is best, all of these things are things that now come up in question. So we have more questions than we did before, but actually this is the step in the right direction. At that stage, I'm going to say thank you, and I will welcome any questions. Thank you very much. I think Elaine had to go, so I will give you the mic.
Okay, I have two questions. Bon, my first question. When I fit a lens that is for instance, a myosite or, you know, all those lenses in eyeglasses that are made to, okay, I really have to center my, put the optical center right in front of the eye. I happen to see a lot of Asian little children who actually don't have much of a bridge, okay? And no matter what I try, the way I fit them, no matter what I do, the frames that I pick, the way I measure, the glasses end up sliding down slowly on their nose, and eventually they're not looking through the target that I was planning to. And then they look through the whatever, the honeycomb or the circles, or no matter the lens that's been fitted. And they complain, and some of them complain about it because they find that they don't see as well. And then we try to readjust, we try to mount or change the position of the optical center so it sits down. Now, what happens is, finally, sometimes I say, well, we should wear a strap or something in order to keep the glasses that high. But it is, in the real life, it's difficult, and I'm having a hard time sometimes. What do you think about that? Have you ever heard this story? What, do you have a suggestion? I have another question after.
Thank you. It's a very good question, good point. Centration is very important. It makes sense in theory that if there is an issue with the child not being fitted at the center, the efficacy might reduce. No one has actually ever done a study where they've proven that, but the evidence would think that that would be the case. Now, many manufacturers have actually looked at what the visual change or impact is to not look through the center. And most of the papers will show you that the effect in terms of clinical measurement is low. However, I agree with you, when I've had children that are not wearing it completely perfectly, thank you, not wearing it completely perfectly, they are less happy and they will complain about it. The only suggestions I've had from my own experience is to try a frame that I'm very happy does fit. So either a custom fit lens, if it's a really difficult patient to find a face fit for, I will fit a custom frame. Alternatively, if that's not an option because of expense or whatever reason, I'll consider something like a contact lens. I can get rid of that with centration. That's the options, but centration is definitely important. It's something that Alicia, someone who's also spoken at SILMO before, mentions at length, because we never, in many of the studies I reported here, centration was not something that was discussed in their original reports, and it would be interesting to look at whether centration had an impact on the different range of treatment efficacies that were taking place. It's a very good question.
Okay, thank you. Now let's go for contact lenses.
Okay.
Let's say you want to fit a contact lens that has been created to reduce the progression of myopia.
Yep.
Like for instance, Cooper Vision, for where I live, okay? This is the lens that's being used. What happens is those lenses are all spherical only, and they have a small range. They don't go very far as protection. I think you can't go any further than -12. Now, not being able to correct astigmatism when you are at -2 or 3 diopters of astigmatism, and you put a spherical lens on the eye, you have a problem. Once again, the child can't see properly. Now, it brings me to another subject. I've been fitting hard and gas permeable contact lenses for the past 50 years. Okay? And very, very often, in fact, I will tell you, probably 90% of the time, people that I've fitted on, the flattest base curve of the eye, a hard or a gas permeable lens, okay, I have seen that the myopia was not changing, was very stable, all the way from the age of about 12 years old, all the way to the adult life. And what sometimes I will have a tendency to say to people is, this would work. It's going to correct your astigmatism. We can go all the way with any kinds of prescriptions, and eventually you're going to become an adult. And then once you become an adult, hopefully science, ophthalmology will find ways to correct or to stabilize your situation. Okay. However, I do not recommend that you stop wearing those lenses, because my experiences also is that if these people stop wearing hard or gas permeable lenses when they are 22, 23 years old, okay, myopia comes back. I noticed that from -7 or -6, they are going to end up with -8 or -9 in no time, because they switched to one-day disposable contact lenses. Okay. They have decided to do that, and I'm in a situation where I say, my only possible way, okay, to, by experience, not flatten the eye, because it's not in Kyoto, the business overnight. It's during the day, every day. You wear them all the time, of course. You wear your glasses also. Yep. But at the end, okay, you wear them all your teenage years, you wear them all the way to your adult years, and we hope for the best. What's your opinion about that?
Okay, so interesting question. If I can summarize the question, it's essentially, what about RGP lenses or hard lenses, and the avoidance of daily disposables or soft lens designs? Is that the summary of the question?
Yeah, trying to fit a hard lens tailor-made in order to correct not only the myopia, but also the astigmatism that comes with it. So,
I have experience of fitting RGP lenses, I think once or twice to children. I've not had the same effect of it slowing down the amount of myopia that's happening. The thing to bear in mind is, it may be similar to how if you have a spherical RGP lens on a toric cornea, you can mask some of the astigmatism. You might be masking some of the myopia progression or change. That's very hard to decide, and the peer-reviewed studies that have come out show that actually the amount of myopia and axial length growth, they continue on average with RGP lenses.
Absolutely, and I ended up with -14. With my right eye, I had a giant retina detachment. I lost my right eye. On the other side, my retina was ripping. I had laser surgery, whatever you want in order to correct, and eventually cataracts and everything. And my eye is very, very deep. My eyes are very, very deep.
Yep.
In other words, I was wearing hard lenses when I was a child. I wore hard lenses all the time. It did not stop my eye from growing.
I see. Okay.
Okay.
Well, this might be the case. However, what your comment about with soft contact lenses not having a toric element or astigmatic element, watch this space. That's about to change by the end of the year. There will be new lenses that might be daily disposable, might not be, or with myopia management in them, but also toric, because they already exist as monthlies. Mark Enevy did them, for example, but they might be coming out in daily format soon too. So what I'm saying is the issue that you had with the toric part, that might be an issue of the past.
So at your opinion, I should think soft, and I should be optimistic about the fact that the range will be more available.
So the range has gone up to 12. I appreciate with the
12
very
now.
myopic people, that's difficult.
But 12 total.
Yes, that's
12
right.
total, including
Correct.
astigmatism.
I would honestly go as far as to say, if I have a child who's myopic beyond the -12 point, that myopia isn't typical myopia. That's atypical, or something's there that isn't just simple myopia to the level that we're thinking about in most children. So I don't know if even the treatment would work for those children. That's why they haven't gone that high. It's a good question. The answer I can give you, unfortunately, is we just don't have evidence for it. I don't know. I wish we knew, but when it comes to myopia that's kind of at that level, where you have more diopters than you do age, that is usually atypical. It's either a kind of a syndromic, something's up, or it might be that the myopia is something that isn't just going to continue with normal resistance.
So if that's the case, I suppose that to give the best possible vision is to still stick to hard or gas permeable lenses.
Potentially. I mean, the idea is similar to here. We don't know if it would work or not. It might be worth trying. Something, even those soft lenses with MySight technology, for example, to see if it will work, but it can't be guaranteed, especially in those kind of children. It's a good question, though.
You see, we go with our experience. As I said, I started fitting those lenses a little less than 50 years ago, so I have tendency to be a little narrow-minded as far as these things are concerned. And also there's the price. It is so much less expensive.
It is much less expensive.
It is so much less complicated. You know, the only thing is we have to convince the child or the young teenager to go through the accommodation, living with those hard, uncomfortable lenses.
I know.
I don't want to take all the space for everybody.
I think there are some questions,
That's
but no,
it.
thank you very much.
Thank you
And then you.
Don't worry, they're great questions. Hi. Just a couple of things on the. We've recently acquired a Maya machine to measure the actual length. So, on your original discussion about knowing when the myopia is increased, if the actual length is static, then can you safely say that the myopia hasn't increased?
It's a very good question. I have this in clinic with my own patients.
Yeah.
I've rarely come across that side. What I have come across is myopia that's stable and axial length that grows. But in the question that you've raised, if the myopia is increased, it depends how much. As much as I would love to say, for example, myself or any other clinician, that our refractions are very good, science has shown that on average we can only be as repeatable as 0.50 diopters. So if it's less than 0.50 diopters, I would trust the axial length much more.
Okay, because I'm doing a lot of ortho-K, so the thing about ortho-K is you never actually know what the prescription is.
Yes.
You start off someone's -3 and they keep going with the ortho-K, and so in 5 years' time, you say, well, what's my prescription? You say, well, I don't know, because you have to wash out to get the prescription back. So surely the only way to say to the client or the child or the parent, your eyes haven't got any worse, is the actual length measurement.
I actually completely recommend that. That's what I do in clinic as well for ortho-K
And
patients.
also on the actual length measurement, obviously, because it's a fairly new metric in the profession, we never quite know what is relevant. If it's 26.21, then you think, okay, 26.22, has your eye got worse? I mean, it's the...
Very good question.
Yeah.
The repeatability of most measurements is capped at 0.06 millimeters. So if it grows by 0.1, you can be sure that generally that's actually growth. Whereas if you have anything more than that, so you know, if it was 22 millimeters before and then it's 22.2 millimeters, let's say, that's growth. That's definitely growth.
Say that measurement again, sorry.
Sure. So every machine is repeatable to generally 0.06 millimeters.
Yes.
So that means if I measured it one day, the value I see could be 0.06 that way or that way.
Okay.
So if it's over 0.12, I'm sure it's grown. Does that make sense?
So 0.606 we don't bother about.
No.
Yeah. Another question, just quickly. Sorry,
Sure.
to hold the thing. I noticed that the word myopia control is obviously old school now, I presume. I noticed it's been chucked out by the profession, chucked out by your talk, because obviously using the word control means that we can't control it. I know management is now the new word, the new speak. Would you agree? In the
No.
Oh, okay.
So it's interesting you say that.
Yes.
Myopia management is the term for the umbrella that is
Okay.
all of this. Myopia control is actually something that the in the UK, for example, is the licensed power. So, for example, in the UK, certain ones are licensed for myopia control.
Yeah.
And what that means is that they're actually licensed because they have evidence for controlling myopia of some form.
Right.
Myopia management, believe it or not, you can get a license for in the UK with a simple single refraction, single vision.
Okay.
Because it's still a way of managing a myopia. So it's an umbrella term. That's why. If you look at, we did a paper on this. If you look at the Google search terms, myopia control is a lot more familiar to most of our patients than myopia management
Yes,
is.
of course it is.
But you're right. It's something that's changing over time.
Just one quick final question.
Sure.
With the Ortho K, you can use that in conjunction with atropine?
Yeah, there's many studies that have done
And
that.
how often would you put atropine in? In the evening? One drop in the evening?
Usually
or something?
atropine is used in the evening. So one drop in the evening per eye or whichever eye is
Right,
of relevance.
So very easy to use.
But actually the most combined therapy that's been done is atropine and Ortho K.
Yes,
So, yeah.
which is what I would like, when it gets licensed UK.
Which
yeah.
will happen very soon.
Good.
Yeah. Thank you. I think there's one person at the back, sorry. Thank you for your patience.
Yeah, thank you. Thank you very much. That was a nice presentation. Can you hear me?
Yeah, now
Okay, I have something. My experience is a bit similar to his experience. You know, for myopia control lenses, so because of the different races, our nose bridge is a bit different.
Yes.
So when you fit glasses and the PD does not coincide with the optical center of the lens,
Yep.
the frame is going to drop and the
Yes.
patient is going to come back complaining. So
Yeah.
what we do, like I have a similar experience to what you said. So you look at the nose bridge, because I do myopia control in Nigeria. Our nose plane is different. The Caucasians, Africans were different. So in your choice of frame, in picking frames, you must consider these nose pads. The nose pads for Asians, Africans, and other races, they are a bit different. And if you don't put that into consideration, you're going to have a disalignment between your PD and your optical center. And the frames, they're going to drop. So I hope that helps. That's what I do in my
Frame
practice.
selection is important.
Then
Agreed.
for the questions
Sure.
I have, in your slide, you talked about hyperopic defocus
Yep.
and myopic defocus.
Yes.
I didn't quite understand the contrast you were trying to make
So-
in both.
Basically, one study looked at if we focused it in front of the retina and actually the same with behind the retina.
The retina.
And interestingly, both worked. They shouldn't have. We thought one would work to stop the growth going backward, but both worked. And that's where the consideration is, why did both work? Potentially contrast reduction.
Okay,
That's why.
but you know that myopia control lenses are based on those principles.
Yes, that's right.
So
That's
does
why
it
we were
mean-
surprised. It's based on myopia to focus.
Defocus.
That's
Okay.
right.
Okay, lastly, my recent survey on digital eye strain highlights high screen dependence in young populations. I did that in Nigeria.
Okay.
I found out that 18 to 40 years of age, they spend more than 6 hours daily
Okay.
on smartphones and other digital devices. So given the evidence linking prolonged near walk, reduced blinking, and limited outdoor exposure to both dry eye symptoms and myopia progression, what practical approaches can clinicians adopt to jointly address these issues, in your opinion?
I think it becomes a matter of being difficult with the child. You have to kind of be honest. So the evidence is that, you know, being indoors, being on computers, reading, anything like that is a risk factor. It's a behavioral risk factor. So try and change that risk factor. Now, interestingly, the one that's been most consistent of all of those is time outdoors. So if you're going to be on a screen, do it outside. I know it sounds ridiculous. Do it outside.
Sounds ridiculous.
Go on a laptop. But sometimes it works. Get your tablet, go outside. You've got a brighter light. You've got the light in here, it might feel very bright, but if I just walk just over there in the shade, absolutely tons of more lux than I would do here. And light has been, that's the consideration we have for myopia, the amount of light. Now, you say you're in Nigeria, I'm sure you get a heck of a lot more light than we do here.
Yeah.
So no one's looked at the amount of light you need, but even if you can get 2 hours of light per day, you can potentially combat the impact of the effects that you have when you're indoors on screens.
Okay. I'm a fellow of the American Academy of Optometry, and in one of my research papers on dry eye and, digital eyes, relating it to our own country, Nigeria, we found out that, Africans generally, Nigerians, we don't really take dry eye serious.
Okay.
And we ignore the symptoms from digital eye strain. We don't also pay attention to myopia control until the myopia is quite significant. Yeah. So are there measures, are there ways we can, in your opinion, that we can use to catch this early to help our population?
Myopia progression, biometry is the answer I would give you. I would honestly think it's a new technology you were saying. I would argue, and I am currently writing a paper to argue this, everyone should be using it. Because it will show you, if you can show a parent, just like prescription's increasing, but you can show the eye length is increasing, that is more powerful because it's much more sensitive. It's a much more sensitive measurement. You will get a change in eye growth before you get an actual change in prescription. And actually you'll be able to, and this is a thing that's been shown, you can generally estimate when myopia is going to happen because there's a massive jump and then suddenly you're like, oh, okay, I need to act. So that's what my answer to that would be. I need to move on, guys, because people are behind me are very upset. Please
Thank you very much.
Though. Thank you.